your host. My name is PJ Matras, and I'm the clinical nurse specialist for pain management here at Providence Healthcare. And Jennifer Hansen, who is the director of education at Pain BC. We will be the ones hosting all your questions. All right. Next slide. We would like to acknowledge that this conference was organized and is hosted on the transitional unceded ancestral territories of the Musqueam, Squamish, and the Tsleil-Waututh First Nations. Due in part to colonialism and systemic violence, Indigenous people in North America experience a disproportionately high prevalence of chronic pain. Therefore, we invite those of you in the audience who are also settlers to approach pain management in the spirit of decolonization and a commitment to learn and do better. We know that some of you are joining this conference from other places, so we encourage you to take a moment to reflect. Next. And it is my honor and privilege to introduce Fiona Dalton, who is our president and CEO here at Providence Healthcare. Take it away, Fiona.
Thanks so much, PJ, and it's absolutely my pleasure to welcome everyone here today. I remember very well doing this a year ago, and you know what a different world we had then. So there have been so many negatives and pain and trauma in the last year due to COVID, but I think we also there are small positives, and one of them is that clearly we can now use technology in a completely different way. And it's really exciting to see how, because of that, we've got so many more people who are able to participate in today. I've seen the map of where people are from around the world, and it's exciting to see international engagement, and particularly as a personal pleasure for me, nice to see that there are some people, some countrymen and women from the UK who I hope are logged in. As Providence Healthcare, our focus has always been on those groups of patients that other people aren't looking after, often the marginalised, the needy, the unglamorous groups of patients who are often suffering both medically and socially, and working in an interdisciplinary way with compassion and innovation to do things differently. And I think that those patients who so sadly suffer with chronic pain are just such a great example of that. And so I wanted to say a big thank you to everyone here today who are working so hard to address this incredibly important group of patients and unmet need. One of the sad things about my job is that I often get asked to do an introduction to a conference, which I absolutely want to do, but then I look at the program and it all looks really, really interesting, and I think I absolutely want to stay and hear each one of those sessions, and unfortunately my diary doesn't allow me to do that, but having looked at the program, it does look fantastic, and so I hope that today goes really well. Thank you so much to everyone who's put the effort into organising this conference, and all of the speakers, and thank you to everyone who's taking the time out of their busy day to engage today, and I hope that it is as enjoyable, informative and thought-provoking as it looks to me to be. So thank you very much, everyone.
All right, it gives me great pleasure to introduce our good friend Keith Meldrum. Keith is a patient advocate and a very popular speaker, so we're really lucky to have him today. Keith has lived with persistent neuropathic pain since 1986 following a near-fatal vehicle accident. In 2012, he was appointed to the board of directors of Pain BC, a leading pain advocacy nonprofit in BC, where he served as the vice chair and chair of the government and nominating committee until 2018. Following this, he has focused his attention as a personal advocate. This led to an invitation to present at the International Association for the Study of Pain's 2018 World Congress, as well as his appointment to the Global Alliance of Pain Patient Advocates and IASP Presidential Task Force. Keith has presented locally, nationally, and internationally, and has delivered numerous webinars and has authored 2 articles on living with pain. And it's just always a pleasure to hear Keith speak, and I'm really excited to introduce him to you now.
Great, thanks Jen, I appreciate that. And I'm just going to open up my, sorry, I just gotta screen share here. And one moment, please. Thanks, Jen. I really appreciate the opportunity to come in and meet with everybody today. This is a really special event for me. I have a real personal connection to Providence Healthcare. So I'm really, really excited to be here today and to get a chance to talk to, I understand, over 600 people. So what I'm going to do today, and just looking to have sort of more of a conversation with everybody who's online with us today, spend about half of my time just talking about my personal experience with pain, because I think it's important for healthcare providers to understand a bit more of the totality of a person's pain experience. We're certainly much more than just our pain. It's how it affects and intersects our lives every day. And then spend a few minutes at the end just talking about and offering some takeaways that I would offer to healthcare providers that I've learned throughout my time through this journey, for lack of a better word. I'm not a big fan of that word journey, but I don't know if there's a better word. So, so with that, I will sort of jump right in here. And first thing I need to do is my presenter disclosure and conflict of interest. As a presenter, I presented and been financially compensated as a lived experience educator, presenter with the Canadian Pain Society and the Bill Nowns Pain and Research Center, which is a local clinic in the city that I live in. And I am currently part of a research team at McGill University with their Faculty of Medicine. As noted in the opening, thank you for that, Jen, I'm a member of the International Association for the Study of Pain, and I'm a member, volunteer member of the Global Alliance of Pain Patient Advocates, and was recently put on the Global Year Against Back Pain Task Force. So I sit on those two as volunteer members. And that is actually my conflict of interest disclosure. So I'm just quickly going to touch on a few of the things that were already in my bio. But before I get into sort of my story or my experience, just a little bit more about me. I am by profession a civil engineer technologist, and I live in beautiful Kelowna, British Columbia, Canada, which is currently, as I look out my window, snowing quite heavily, which is terribly unusual for this time of year. So they tell me it's not going to last, which is good, but it looks beautiful out there right now. I'm married with an adult stepson, and we have our lovely miniature Australian Labradoodle that lives with us named Parker. And because I'm at home, if somebody walks by on the street, we might even get to hear her join us today. So my experience with persistent pain goes back a number of years. I was involved in a near fatal single vehicle motor vehicle accident on August 10th, 1986. And that was my introduction to persistent pain. So that is just over 34 years now. 2/3 of my life I have lived with persistent pain. As I mentioned, I have a real connection to Providence Healthcare. I am a patient of St. Paul's Hospital. In 2005, I was trialed and given a spinal cord stimulator, and I remain part of that program with St. Paul's Hospital. As Jen mentioned, a number of years ago, back in 2011, I turned my attention and focus to pain advocacy because I saw there was a tremendous gap in the healthcare system. And I won't reiterate it, but I spent time with Pain BC and am currently a member of the International Association for the Study of Pain, doing work with them as well as my own personal advocacy work. I presented a number of conferences locally, nationally, and internationally. I have a small Facebook blog that I every now and then dump some thoughts on, which I would love if anybody would like to read. You can find it on Facebook. It's called A Path Forward. And as I mentioned, my attention is now getting into research. I joined the McGill research team, as I mentioned. Our topic is advancing the conceptualization and assessment of pain-related suffering. We just started this process. The grant was recently approved. And this is founded on the work of Dr. Eric Castle, so it's something I'm really excited about, and was recently just invited to be part of another research grant. So I'm really excited to get into the research. So with that, just want to take a few minutes. I've got a couple of slides, but really, like I said, I just want to have a conversation here, so talk about sort of my experiences, and then my takeaways, what I've learned, and what I hope I can pass on to both healthcare providers and those 200 that are also living with pain. Hopefully validate some of their issues. And understanding this is my story, while there's a lot of commonality to people who live with persistent pain, everybody's different, and how it affects every person is unique. So as I mentioned, I had an accident. It was a single vehicle motor vehicle accident in August of '86. This was caused, it was a new driver, I was 16 years old, made some poor decision making based on just sort of a lack of understanding of what it's like to be able to drive, and being that young adult, I had my driver's license for a few months. And I had been at a provincial campsite about 75 kilometers north of where I lived in central British Columbia at the time, camping with my friends at my high school job. I worked at McDonald's, like so many others, and the poor decision making was being up for most of the night, and despite promising my parents I would never do something like this, had consumed a fair amount of alcohol and got a tremendous lack of sleep. So when I left the next morning, early morning, around 7 a.m. I believe, I was essentially still impaired, but I didn't know it was between the alcohol and the lack of sleep. I got maybe 2 hours worth of sleep. And what I didn't know was, and I'm sure many can relate, is that you could actually fall asleep behind the wheel. Just the concept that was just completely foreign to me. I don't remember much about the accident itself, but the drive, like I said, was about 70 kilometers back to where I needed to go. And it was a cool August morning in central British Columbia. And I had created an environment in the car where I rolled up the windows, turned the heater on, and created this nice warm environment. And between that and the impairment, caused me to just fall asleep. And about halfway back to town, I left the highway at highway speed, I'm told. The highway was an elevated curve, so the highway went up and banked it off to the right. And because I was sound asleep, I just kept going straight forward, and it pitched it over the bank, the elevated curve, and the car rolled down the bank. It was an older vehicle, a 1972 North American car, so it had a split lap belt and shoulder restraint, and it was only wearing the lap belt. Because I do recall putting that on thinking I didn't want to get a ticket. But because I had fallen asleep, and I had but I slid down in the seat because I had slumped down from being asleep. Instead of the lap belt being across my hips, it was across my abdominal wall. And while it kept me restrained in the car as it rolled end over down the bank, things like the door flew off, and I remember some parts of it. The action of the car rolling end over end and me snapping back and forth over the seat belt, and with the belt being across my abdominal wall, caused significant internal trauma. It tore through my abdominal wall, my large and small bowel, right into sort of my stomach, and caused significant trauma and damage. And in fact, I was bleeding out, and I'd lost a significant amount of my blood. I was fortunate. The accident was witnessed. It was in central British Columbia on an August morning. At that time, there's not a lot of highway traffic, but through a series of very fortunate events, people who saw my accident flagged down a vehicle. That vehicle was able to radio back to the city that I lived in, because this is the 80s and cell phones didn't exist, and be able to get an ambulance coming. Ultimately, I was able to get transported to the hospital in time, but I do recall laying on the ground after I self-extricated from the car in a pain that to this day I cannot describe. And all I do recall going in and out of consciousness was the people who were beside me just sort of comforting me. I just kept praying to die because the pain was just something that was indescribable. Fortunately, that didn't happen. I did make it to the hospital. And that was the introduction to what has now been 34 years of living with and learning how to manage persistent pain. The initial surgery was nearly 7 hours and was an extremely complicated surgery. And when it was done, the surgeon told my parents that they had done all they could do for now, that I was going to live, but that there would probably be more problems later on. And there have been. Over the next few years, I wound up having multiple surgeries. Initially, my large bowel was so damaged that they couldn't repair it, so I had a temporary colostomy, which required a reversal. I had a number of surgeries for bowel obstructions over the years. And throughout all of that, underlying all of that, after each surgical repair was just pain. I just kept always having pain, and just really didn't understand it. And that started me on this path of not understanding why I had pain and thinking that I just needed to find the right intervention, or they needed to do the right surgery to fix it. But throughout that, I kept having multiple interactions with the healthcare system for pain control. I would just sometimes almost be doing nothing, and I would get blinding pain that would require me to go into the hospital and go into the emergency room. And for those who are joining us today who've had the opportunity to go to an emergency room for a flare-up of a chronic pain, it's probably one of the worst situations you can be in. It's terribly dismissive. It's terribly invalidating. It's not a positive or pleasant experience. But when you are at the end of your rope and you have nothing left and you don't know what to do, you turn yourself over to a system that is supposed to help you, and it's often a very challenging process to go through. And like I said, underlying all of this was this ongoing, relentless, at times, pain. And again, I was just convinced that they just hadn't done the right surgery, they hadn't found the right intervention, and I just needed to keep finding the person or the doctor to do the right thing. Throughout all of this, I was dealing with a healthcare system I would offer ignorant to the complexities of persistent pain. And by ignorant, I truly mean that in the sense of not educated, they didn't understand it. And often that was met with dismissiveness, almost sometimes outright hostility. And one of the more difficult interactions I had was one day I was 19 or 20, I'm not too sure which. And I remember being in my family doctor's office and we're sort of talking about this and we trying to figure out what's going on and, understand I've come through a rather traumatic experience to which I was never given any kind of support or told that, at 16 you nearly died and this might cause you some sort of challenges in your life, not only physically, but emotionally and psychologically. And I'm trying to figure out what's going on. And I think it's me and I'm not trying hard enough and the doctors aren't trying hard enough. And sort of the quintessential dismissiveness that I received was when my family doctor looked at me and said, "We have fixed everything that can be fixed. There's nothing left to fix anymore. There's nothing wrong, and it's all in your head." And I'm 19 or 20 years old, struggling with trying to understand what's going on in my life myself. And now I'm told by a doctor who in the medical system is always sort of, above you, and they are, they're the experts. And now I'm stuck with, "You're nuts." And I left his office just completely twisted up, more so than ever before, because now what I'm fighting is, why am I making this up? Because that's what I thought he was telling me, was that I was making it up. And am I attention seeking? Am I crazy? Is there something wrong with me? I don't understand it because the pain sure feels real. Why would I put myself through these things? Why would I put myself through medical interventions where I have needles stuck in my body to try and make the pain go away? And some of the medical procedures, the interventions, are not without discomfort themselves. But why would I continue to do this if it's not real? It was terribly dismissive and caused all sorts of stress in my life and just redoubled my effort to try and power through, because then I thought, well, it's just got to be me. So that then set up the next number of years of me just pushing and powering through, thinking the only way to get through this was to just push and power through. And all that did was create more of my pain, because I would put myself in situations that would just increase my pain, because I thought I was showing how tough I was and how I could get through this, because obviously there's something wrong with me. It's all in my head. Meanwhile, I'm still searching for somebody to fix it. So I had my foot in both waters, and often led to my own sort of internal confusion. And I would go some days back and forth between, no, this thing is real, because I could feel it. And I must be overly sensitive. It can't be that bad. And it was very, very conflicting. And that was due a lot to a lack of understanding by the healthcare professional what pain is, the complexity of pain, the totality of pain, and how it affects somebody's life, and how we're more than just our tissue and our damage. It's all of the other parts of our lives, the psychological and the emotional parts that impact and inform our pain. But none of that was understood. None of that was ever relayed to me. And so it was just trying to figure this out, being on a journey with no map, having no idea where I was going. And as I note here, I was seeking the panacea. As part of this, I was convinced that if I just found the right doctor who did the right medical intervention, whether it was a needle intervention, whether it was a surgery, then this would be fixed and I would be better. And until that came along, my role was to just keep powering and pushing through. And that caused me to make some poor decisions. One of which was I was 21, so not too long after I was told it was all in my head. And you have moments in pain, or at least I did, where it's less. You're in a valley, and it hasn't peaked. And when you're in those valleys, you can sort of live and tolerate and get by. And I was going to show the world, meaning myself, that I was not my pain. I was not my accident, because it was just critical to me that I don't be defined by that. And I joined our national military. I joined the Canadian Armed Forces, and threw in an application. I was going to show the world. It's 1991. And when I was going through my medical exam, which was fully disclosed by the forces doctor, saw my medical history, and he said, "How are you now?" And I heard the words, "How are you now?" And as I'm sitting in his office, I'm fine, as I am. So I answered it truthfully. And before I know it, I'm on a plane being shipped to the other side of the country. I live on the west coast of Canada. I'm shipped to the east coast of Canada to begin my recruit training. And what happened was, partway through my recruit school training, I absolutely collapsed and wound up in the hospital and having more surgery. And when I was in there, they were like, "How did you even get here? What is going on?" So I kept setting myself up for these failures, for lack of a better word, but it was just, it was so important to me to show the world that I was not defined by my accident. It was not defined by my pain. And nobody had ever given me any tools, or had ever told me that this is a really traumatic experience that you went through, that you can have ongoing pain, and there's things that you can do to manage it, because they just didn't understand that. So throughout all of that, like I said, one foot in the water of saying I need to just power through, while continuing to look for solutions. Part of that was my introduction to St. Paul's, and this goes back to 2004, 2005. In 2004, I was receiving paravertebral nerve blocks, which had limited efficacy. And I believe I went through about 3 rounds of those, and that procedure alone isn't exactly without some discomfort. But anytime an intervention is more painful than the pain, then I always felt I didn't need it. But the last rounds was that we had a little bit of a problem in that I suffered a partial pneumothorax when the anesthesiologist went a little too deep with the needle. And it was at that point he said, "I think this really isn't the solution for you," because we weren't getting any lengthy effect from it. And he, in a sort of offhanded way, but he was the first one in years who gave me a solution going forward. He said, "I don't believe this is working for you, but have you heard about this thing called spinal cord stimulation?" And it was really, like I said, offhanded, but it was the first time somebody gave me a path. And he said, "You might want to look into it." He wasn't overly enthusiastic about it, but he still recommended it. And when I said, "I think I want to look at that," after having discussed it with my wife, set up the process for the referral. And that led me to meet the team at St. Paul's Hospital, where I went and I'd go through the initial intake. And through that, there was a turning point for me. And this is now 2004. So from 86 to 2004, it was mostly dismissiveness, doctors saying, what do you want from me? We don't really think it's that bad. All of those more negative interactions. And when I'm going through the intake with Dr. David Hunt at St. Paul's Hospital, and I'm doing my medical history, as I've done probably 40 times by that point in my life. So you do it by rote. And again, for those of us joining today who have a chronic illness and live with your chronic pain, you just repeat it. You're almost not even listening to yourself, which I'm doing. And as I'm going through everything, I realized at some point that he's not writing anymore. And I thought, oh, I've done it now. Now it's all coming back to me. It's all in your head. I really am crazy. They know there's nothing wrong with me. I knew there needed to be a psychological evaluation as part of this. And I thought, I didn't even make it that far. He's figured out right now in 10 minutes that I'm nuts. And with a little bit of sort of fear, I kind of look over to him and he puts his pen down and Dr. Hunt says 3 words that literally changed my life. He said, it's okay, we believe you. And that validation was the first time in nearly 20 years somebody had done it, that had validated my pain. They hadn't dismissed it. They hadn't tried to push it aside. They didn't try to tell me it wasn't as bad as it was. Or they didn't try to tell me I can't help you and there's nothing more that we can be done. And that was an intersectional moment because that was the beginning of a long journey, because it didn't happen overnight. It was the beginning of the journey where I was at this intersection and I was able to move in a different direction, which ultimately led me to learn more about what persistent pain is, how I can live with it, to learn about it, what I can do for myself, how to advocate for myself, how to work with my healthcare team, but also what I can do to learn to live better with myself. And that is a critical intersection moment, because I remember at one point when the surgeon told me there was nothing more that they could do for me. The surgeon said, if he opened me up one more time, he thought he would make it worse. And he said, you're probably going to have pain for the rest of your life. I was just, I just didn't know what that meant. I didn't think that was even possible. So to understand that the healthcare team validated me and said that, yes, this is real, and here are the things that we can do, and started to open doors for me as to what I could do for myself, allowed me to go down a new path. And again, it did not happen overnight. It took me a long time to start to be open to understand what I could do for myself to help live better despite the pain. That is hugely important, because as people who live with persistent pain, we do need to participate in healthcare. We cannot give it all over to the healthcare system, because as much as I have the utmost respect for a healthcare system and the doctors and the nurses and all the healthcare practitioners, I am 100% a participant in my own healthcare, and I need to be that active participant, and we need to work together. And we use terms like collaboration and therapeutic alliance, but those are so critically important. So the first half of my 34 years almost were this stumbling, fighting through a system that really didn't support me, mostly because they didn't understand it. And because of that lack of understanding, just dismissed me. If I can't help you, there's really nothing that we can do. And I would often just be turned aside and given no direction. So this moment of we believe you truly set me on a different path. And I don't know what my life would look today if I didn't have this interaction. So I mean, I say that over and over again, but I can't stress that enough about how important it is to validate somebody's pain experience. So I just want to take a few more minutes here, a few minutes left, and just from that, what I've learned over the next 17 or 18 years, and offer this to those joining us at the healthcare providers, and hopefully this will resonate with some of the 200 that also live with pain, about what it is like to be on the other side, supporting people who have pain, and what I think is important, and what I've learned, and what I believe is necessary to meet somebody in the middle and have that truly therapeutic alliance. So very quickly, there's lots of talk about the biopsychosocial framework. I'm a huge proponent of that. with the understanding of the biological, and there's still a lot of debate and some almost conflict in this because people like to put it in 3 silos and it's not. This Venn diagram very clearly shows that it is all together. And as one who is a patient, I'm very much sensitive to that it's all 3. It's biological, social, and psychological. There used to be too much focus on the biological as a tissue issue, without any real consideration to the psychological and the social impacts. And I believe that is where the miss has been. And this is when I talk about the totality of people's pain experiences. You need to look at how it affects their entire life, how it assaults, and I don't use that word lightly, how it insults somebody's personhood. That's a bit of an Eric Castle's term, so I have to give that to him. And it really does, because it affects every part of your life. I live with persistent neuropathic pain, which has its odd moments because I can be sitting there doing nothing and have a pain flare. And it took me a long time to rationalize what that really meant. And that can be very disconcerting until you start to understand what that's about. And activism. My note there, if anybody's had the opportunity to read Dr. Stillwell and Dr. Harmon's paper from last year, it's a bit of a tough read. I had to read it 3 times, but it's an excellent paper. And it really was something I clicked into because I believe in activism is such, it's just a great lens to look at that. And in activism, and just a very simple term, and I've got to sort of read it here as a definition, is cognition arises through a dynamic interrelationship between an acting organism and its environment. And with all due respect to the researchers out there, I don't want to get this too simplified, but that's really, we're products of our environment. We are not isolated. Our environment affects us as well. Validation, we've talked about that, the importance of validation. Actively listening to a patient. Many people have read the studies, we've heard about it anecdotally. You go in to see your healthcare professional, and sometimes within 22 seconds of the patient starting to talk, they're interrupted by their healthcare professional. There needs to be a therapeutic alliance. There needs to be active listening. Understand that when that person comes in to see you, they're coming into you with so much more than just their health issue, their pain. They're coming into you with their life and how this pain experience affects their life. And they need time to talk to you about that. And I realize the healthcare system isn't really well designed for this and we need to change that. But they need time for you to listen and to actively listen. And the words that people use back to a patient are terribly important. I have a dear friend of mine that I do lots of presentations with. She went to see a doctor and she was introduced as, your 2 o'clock hip is here. And that just resonated with her, is that I'm not a person. I'm just nothing more than a case file. I experienced a lot of that numerous times with the doctor literally talking behind my medical charts, back in the old days of paper charts, and you hardly saw the face because you were just a chart. And they would literally put that up as a barrier between you and them. The words that we use matter tremendously when we're dealing with people, especially people living with pain. Again, there's the psychological and the emotional impacts that need to be considered in this. And for healthcare providers, you can't know everything. I know I was always looking for people to have all the answers and know everything. I was desperate. I also felt like they didn't know. I thought they didn't care. What I've come to realize is don't know all the answers, but that's okay. I would suggest that it's okay. It's important to embrace that and say, I don't know, but let's find out. Let's work together. Supporting people, validating them, working with them. That is the foundation they need, that we all need. I still need to this day to be able to move forward. So it's okay to say, I don't know, but let's see what we can find out. This speaks to person-centered care, therapeutic alliance, collaboration, all of these terms which get bantered around, but are really, really critically important. You're dealing with the totality of somebody's life, not just their pain. This is somebody who's got everything else going in their life. They might not be able to work. They don't know how they're going to make their rent. They have no social supports. Their friends and family have given up on them. This is tremendously impactful, and that's why, as Eric Castle says, it assaults their personhood. It is not just a health issue, it is a life issue, and it can be devastating. And over years, it can just slowly erode the foundation of people's lives. That's what we need to look at. Take a step back and broaden your lens when we're dealing with people and their persistent pain. I'm going to end on what those of us that live with pain can do for ourselves. And this is supported self-management. And you'll see I've underlined supported. We used to talk about this as self-management, and I'm promoting strongly supported self-management because very often, and I've heard over the years, when people who live with pain are talking, when people talk about self-management, it feels like almost an abandonment as well, where they're being told, again, there's nothing more that I can do, so it's up to you to self-manage this. And that's not what it is, or it's intended to be. As people who live with pain, there are things that we can and really need to do that are proven to be effective in helping manage our pain. But supported means we do this in collaboration with our healthcare providers, because we can't do it all alone. We still need help. And that's the supported self-management. The systems and the resources need to be in place, and our healthcare team needs to be there working with us to support us through that. Some of the basic tenets of supported self-management are first coming to that point to understand I can do something to help myself. And that's the willingness or acceptance. Acceptance can have a negative connotation for some people, so I like the term willingness, but the willingness to say, I have pain, I'm going to be living with it, so what can I do to live my best life despite the pain, which is a different path versus I need to find the answer and get it fixed. That was the path I was going down. Now I live a path of what can I do to help myself and live my best life despite my pain. Again, an intersectional experience. It isn't a one-time process. I even myself often have to come back to this and revisit this intersection and remind myself, there are things that I can do that help me live better with my pain. That is not something that happens overnight. Supported self-management develops within a person resilience or self-efficacy. The things that I do to help self-manage my pain, the movement and the exercise that I do, does not modulate my pain down. Neuropathic pain is certainly different than things like musculoskeletal or nociceptive pain. But despite the fact that it doesn't change my pain positively, it changes me emotionally and psychologically because I've taken control, I've done some things, I've gone outside for movement, I've done a run where even though it hasn't helped my pain, I moved, I did something. And that makes me feel so good and so empowering. And it's a locus of control. It's, I have taken back this control. I'm not letting it run my life. That is healthier than fighting through it, which I used to do. Still do at times, because I'm a slow learner. But it's better to address this through healthy movement and other forms of self-management than the fighting and the battling. So the supported self-management is absolutely critical. So with that, I've pretty much taken up my time. And I would just like to thank Pain BC and Providence Healthcare for this opportunity. I am so excited to have this opportunity to talk to you, and understand there's over 600 people from around the world with us today, and I'm just literally beside myself. And I'm just going to throw out my contact information here. I'm always open to contacts. I love to connect with people. And I hope our healthcare providers and those that are living with pain have been able to find something that's resonated with you, or that you get a takeaway from my presentation this morning. So thank you very much.
Keith, thank you so much. That was a really, I've heard you speak before. It is always fascinating and moving, and just a terrific presentation. So thanks for sharing that experience. We do have a few minutes for questions. So we'll take questions for about 5 minutes, probably 6 minutes. And we've got a couple already in the Q&A, so I'll read those to you. I do just want to note to folks that I did share the Keith's blog in the chat if you want to have a look. And it's always interesting and it's always insightful. So do definitely have a look. Okay, so Keith, a couple questions from folks listening. One person, a healthcare provider, who is just asking if you got any rehab support through ICBC, and the reason they're asking that is is because they are often in the position of helping adjusters understand clients' pain symptoms and you know, how to respect and support people managing a new diagnosis of persistent pain, or yeah, and sometimes that is a little bit at odds with what the insurer wants, which is a quick program discharge this person, right? So what's been your experience?
So my experience with ICBC ranked up there with E in the bucket of terrible. It was a very adversarial relationship. I didn't even know at the time that there was a claim that I could make with ICBC until it was actually the police officer who charged me after my accident said you should talk to them. But it turned out to be just a very they just fought tooth and nail, and there was nothing about any kind of rehab. They paid for a little bit of medical treatment. They covered some medical costs for me to fly from where I lived in central BC to Vancouver for some treatment. It was minimal. They did everything they could to wash their hands of me, and ultimately, in my early 20s, we just simply settled it with nothing and just walked away from it because it was just such a stressful and clearly non-productive conversation to go through. So.
All right, thank you, and sorry to hear that experience. Okay, a couple other questions. How do you see the difference between living in spite of your pain, so for example, joining the army and living your best life with your pain, or pushing through versus living with pain? I guess, how do you define those two things, pushing through pain versus living with pain?
So the biggest thing that I've learned is, like I said, those early years of pushing through was being very bullish, putting my head down and just powering through. And that, again, I use that joining the Canadian military is probably the prime example of just pushing through it and how that's the wrong way to deal with it versus acceptance, understanding that this is going to be part of my life. And instead of pushing against it and railing against it and leaning into it to just power through, taking a step back and noticing that when the pain is starting to ramp up, or I'm getting into situations that will cause me pain, there are things that I can do to help myself. Sometimes it's just relaxation, that's breathing, that's having a conversation with my wife, that I'm feeling it coming on and we can talk through it, and that will help sort of reduce it. So it's dealing with it more from an emotional and psychological perspective versus the early years of just digging in and showing the world that's going to power through, and ultimately just causing myself often to wind up in the hospital for pain control.
Thank you. Okay, here's an interesting question, and it's from someone who works in pharmacy, and they are wondering, when they're talking to patients about non-pharmacological options to manage pain, such as exercise, nutrition, meditation, etc., some tend to interpret that as being dismissive about the amount of pain they're in. So do you have any tips on how to approach these subjects without sounding dismissive?
That is such an important
good question.
It's a great one. I'm asked it often, and really the best advice I can give is, I talked about it being that intersectional moment, that willingness. So myself and others, we all come to that point differently. Not everybody does. That's the thing. We're all individuals, but coming to that point of hearing that message, and the best advice that I can give to the healthcare professionals, the pharmacists, the doctors, is sometimes you're simply planting that seed, and it's a conversation and finding it a way. And I know it's hard to not sound like it's dismissive, but opening that door to say, yes, I understand your pain is real. But there are other things that you can try to help yourself, and try to do it in a supportive way. And often you're just dropping that seed and just leaving it at that and letting people sort of mull on it. For me, I had to keep coming back and revisiting it. I wound up going off and doing my own research to understand what it was. They may come back and want to talk to the pharmacist about that. But if you push too hard, it can feel dismissive because you're going through years of nobody understands and I just need to fix this pain. And now you're telling me if I go out for a walk, I'm going to be better, or I can think my pain away. That's how it can come across. And so it's a slow process of growing and just sort of putting it out there and letting people kind of mull on it, learn some more and come back. And sometimes you just got to try. For me, I needed to try it. I had to try it first. And when I saw the results, and one of the first things was some relaxation and breathing, deep breathing. I had no idea that deep breathing could modulate pain down. And when I saw those results, I'm like, oh, I'm starting to understand this.
Fabulous, thank you. We actually have a lot of other questions, but unfortunately, we are at time. So I just want to say thanks again, Keith. And I guess, you know, you've provided your contact information. If people want to reach out and ask you specific things, is that okay?
Oh, you know me, I'm an open book.
Yeah, yeah.
Absolutely.
Well, thanks for being available, Keith. And thanks again to everyone for attending. We're going to take a 10-minute break. We're going to be back at 10 o'clock for our next presentation, which is the Transitional Pain Clinic team at BGH. It's a really exciting presentation, so I hope you'll join us then. We do have a couple slides from our sponsors, which in this case I believe is Pain BC. So, so please do take a look at those slides, and we'll stay on this link, and we'll see you in 10 minutes. Thanks again, Keith.
Thank you. Bye, everyone.